now we'll go to the last talk of this IC, which is the cataract surgery in eyes with previous refractive surgery. Friends, if you look at this full timeline, you will see that from the era of first posterior RK, which was actually done first time in Japan in 1920, almost a century back, to today's times, smile and contour procedures, we have truly come a long way. But in this entire armamentarium, actually this was the procedure which actually changed the aspects of refractive surgery globally. And this is the first LASIK done by my mentor, Professor Ioannis Palikaris. And this is the first historic video done on the Greek woman. So this was the day when actually the refractive surgery became a magical global phenomenon where millions of people as of today have undergone a very successful spectacle correction with a very pen-free and very safe procedure. Because it became a global phenomenon, that is also the reason that people who have tested the success of LASIK for the first time in their life in 1980s and 1990s, who were called as the baby boomer generation, are the ones which are coming back now today for a cataract procedure. And what we have to know that these people are special. When they come for their cataract, they have a relative lower tolerance for diminution of vision. They are the ones who will come back for early intervention, and they will be extremely demanding because they have seen excellent outcomes of their previous LASIK procedure. However, the irony is that in the patients who desire the most accurate postoperative refractive results, the IOL calculations are least predictable. And the measurements of this corneal power is difficult because of variety of scenarios. That is what we are going to look at now. However, what we have to first understand is how a virgin eye formula works, and then we will go to how the post-LASIK changes occurs. You see that the regression analysis is a very popular formula of the past, such as SRK, SRK2, in which there was a accumulated data which was actually accumulated together to come to this formula. And now new formulas, they rely on theoretical formulas which depend on the concept of the ELP, which is the effective lens position, which is the distance between your anterior refractive surface of the cornea and your nodal point on the internal natural lens. So this distance, which was presumed to be constant at 4 millimeters in the past, but it was seen, of course, that as you have a shorter eye, it becomes smaller than 4 millimeters, and when you have a longer eye, such as myopes, it actually becomes longer. So this ELP prediction in variety of these formulas depends on many factors, many parameters that we look intraocularly for these patients. So when we understand now how the virgin formula works, now let us understand how and why the IOL power calculation is different and difficult after excimer laser procedures such as PRK and LASIK. There are three sources of formula. The number one is the K reading error, which happens because normally the cornea is going to justify and going to follow this K reading, let's say, formula which has proportion of anterior versus the posterior radius of curvature of 1.21. But what happens in people who have undergone a myopic LASIK, the cornea becomes flatter anteriorly, and that actually causes a overestimation of keratometry because that ratio goes haywire. As against that, in patients who have undergone a hyperopic LASIK, it becomes flatter, therefore it causes underestimation of keratometry, thus leading to hyperopic surprises in myopic patients and myopic surprises in past hyperopic patients. The second error is the topography error, because you know that the real keratometry, which is most important for us, is from the center of the cornea, but all our topographers are actually taking it at 3.2 millimeter away, and that is why we get the second error. And the most important error is the formula error, and that happens because all our ELP prediction formulas depend on keratometry, as you can see here, except for Hegge's, and therefore all this formula will lead to erratic outcomes with your IOL power calculation. So in general, if somebody has undergone a myopic LASIK, the patient will have overestimation of keratometry, underestimation of ELP, that leads to underestimation of IOL power and thus leading to hyperopic surprises. So how do we calculate the IOL power in this scenario? The easiest way, of course, is to use the Hegge's formula, because the Hegge's formula does not depend on keratometry, and that can lead to good outcomes. But if you don't have access to the Hegge's formula, then we have to go to the Aramberry double K method for all the K dependent formulas. The Aramberry double K method will depend on the preoperative keratometric reading, which is taken for the ELP prediction, and the true postoperative keratometry reading, which is taken from the pentacam to use in the formula for calculation of IOL power. And when you use this dual Aramberry keratometry formula, then you actually can get very good outcomes. And these are series of different formulas which are actually currently working on advanced level to give very predictable outcome for patients who have already undergone LASIK surgery. Fortunately for us, all these formulas have been clubbed together under one umbrella on this website of ASCRS online calculator, and this actually gives a very good display of minimum, maximum and the median IL power that you will get for these patients. If you look at the studies done, then currently the OCT and the TrueK no history formula have been seen to be the best, especially the Barrett's TrueK formula is currently one of the best formulas that you can use. But what happens in post-RK patients? The post-RK patients along with the first three instabilities also have a lot of corneal instability, and thus leads to highly irregular, highly erratic outcomes when it comes to the biometry, and only 65% cases have shown a plus minus 1 diopteric accuracy in patients who have undergone a past RK. So let us look at this 34-year-old female who had undergone a 16 incision RK like this, and you have to see that she has an extremely small optical zone, has a grade 3 or grade 4 brown cataract, and has led to a lot of differences in their IL power when it comes to both IL master as well as when we have seen through even the ASCRS formula. So in these patients, even the ASCRS formula does not work very well. So this is a small just a overview of post-RK cataract surgery is done. You can see that there are multiple incisions which have been done right from the limbus till almost till the internally to the optical zone. It's a lot of fibrosis around there. You have to be sure that you have a slightly larger axis because we are dealing with a very brown cataract. You have to make sure that you do not make a clear corneal incision when it comes to your main port and make a scleral incision only. And of course, you have to rely on the direct chop technology techniques and use plenty viscoelastic to actually remove this cataract in very safe manner. But what is most crucial here is not only removal of cataract, but also how are we going to deal with the biometry. And I'll share one tool, one trick with you, is that whenever we deal with patients who have more than 12 incisions, actually the biometry doesn't do very well. So at this point, I hydrate the incision, I leave the patient aphakic, and then the patient comes back for a post-operative or intraoperative retinoscopy, and we use what is called as a Maloney's method, where you actually do intraoperative retinoscopy, multiply by 1.7 or 1.8 times, and that is how you select your diopters. And then you go back again with the patient at the same time, or you can also go back the next day and again refill the chamber, implant the lens which has come through this new pearl of intraoperative or a post-operative retinoscopy related IL power calculation. And when we have done this kind of calculations with the retinoscopy dependent IL power calculations, we have seen extremely good outcomes. In fact, as against the literature, our outcomes in 38 patients that we have seen so far are more than 90% patients are within plus minus 1 diopter. When it comes to intacs, actually the IL power calculation is very similar to the post myopic LASIK patients, and most important thing that you should know is that patients who have undergone an ICL implant do not require any change in their biometry, and the same formula can be used as directly from the IL master itself. In terms of the IL choice, in hyperopic eyes, you have to choose post hyperopic LASIK eyes, you must choose a non-aspheric lens such as a Sensar, no financial interest there. But in myopic patients, you should go for lenses which have a negative asphericity. For example, the Technis AMO is the lens of choice for me. And patients who have corneal aberrations or post-RK eyes, you should go practically with a zero aberration lens. And patients, of course, who have a significant astigmatism, you can stick to the toric IOLs for them as well. So this was a small overview of patients post refractive surgery, and I would like to also thank all my co-moderators and co-instructors, and probably we can have a very short group photograph before we give the stage to the next session, please. Thank you.